I have now the honor and the real pleasure to introduce Professor Werner Poewe for the Stanley Fahn lecture. Werner Poewe started his neurology training in Innsbruck, Austria, before he went to the University College in London, and he joined NDS already early in 1988. He advanced his career in Innsbruck, became full professor of neurology in Berlin, and returned again to Innsbruck as the chair of the Department of Neurology in 1995, where he stayed until last year. Already in 2000, he became president of the MDS, followed by many further leadership roles. He initiated numerous projects and activities on Parkinson's disease, multiple system atrophy, and movement disorders with a focus on early diagnosis, imaging, and dopaminergic treatment. He published almost 800 peer-reviewed articles with an H index of 142. In addition to further scientific awards, he received many honorary memberships, including that of the Japanese Neurological Society. Today, he has been elected to present the Stanley Fahn Lecture, which is focused on excellent clinical contributions resulting in better understanding of the cause, diagnosis, or treatment of movement disorders, which is absolutely the case in the complete works of Professor Werner Poewe. He wants you now to understand the challenges and pitfalls in making a clinical diagnosis of Parkinson's disease and the role of imaging and other biomarkers in enhancing early diagnosis and diagnostic accuracy. We are looking forward to your lecture, Diagnosing Parkinson's Disease, from the street to the bench. Please.
Well, thank you very much, Mrs. President Claudia, for your very, very kind words. I would say 2 kind words. Also, thank you, Francisco, for co-hosting this session. It's one of the, in my view, most distinct honors that the Society can give to any of its members to deliver the Stan Fahn Lecture at the annual Congress. It is virtual this time, so I will have to miss, unfortunately, looking at Professor Stan Fahn sitting in the front row and bowing to him, but I'll do it virtually. Hello, Stan. And before starting my lecture, for which I've chosen the topic of diagnosing Parkinson's disease, from the street, and that's where it started, and I'll show you, to the bench, where we're probably going to. If we're doing so and starting, I would like to make a few disclosures. One is that I'm a convinced and stout member of the global community of admirers of Professor Stanley Fahn. And that does not relate only to his excellence as a clinical researcher and his role model function for generations of movement disorder neurologists. This also relates to the human being, Stan Fahn. And for me, it's always been one of my greatest privileges in my professional career and my membership inside MDS to have become collegial friend of Professor Stan Fahn. And I do feel deeply humbled by having been awarded the Stan Fahn Lecture this year in 2020. I have no other conflicts to disclose in relation to my talk. Stan Fahn, as you know, and I think this picture has been shown multiple times at meetings, Stan Fahn is our founding father as far as MDS goes, and one could rightfully say, as far as the field of modern movement disorder research goes. You can see on this historical picture an assembly of to become presidents of the to-be-founded MDS. It was a meeting held in a hotel, the Hotel Atlantic, in Hamburg on the occasion of the World Congress of Neurology in 1985. And here you see the founding fathers and Stan Fahn steering and directing it all. And these people have been so instrumental and important, I don't have to remind you not only Stan, David, of course, the name of the second following lecture, and the others, Joe Jankovic, Andrew Lees, Eduardo Tolosa. And they have remained young. If you look at this picture taken at the MDS Congress in Stockholm, which I think is a nice testimony of Dr. Fahn not only being the most admired, but also the most beloved of all these MDS presidents that followed him. Now let me move to the clinical topic I have chosen, and that is about diagnosing Parkinson's disease. I would want to try and touch in the next 33 minutes or so on 4 aspects. Briefly review the nosological concept, how it developed from the street, so to speak. Spend just a few slides on the pitfalls and the challenges we have as time has passed, and we're realizing those more and more. And then focus on biomarker research, clinical research that has been conducted with the goal of enhancing diagnostic accuracy or performance in Parkinson's disease at multiple levels. And I will focus on imaging because we've been doing some of this work in our group in Innsbruck, and I will in the end also make a few remarks on biofluids and tissue markers. Now, as you all know, James Parkinson developed his nosological concept, his recognition or realization of a new entity that he called the Shaking Palsy, mainly based on observations on the street. He described 6 patients. One of them he actually did follow for years and observe closely. The others he casually saw on the street. And he was impressed with something that you could see at a distance. There were postural abnormalities, a peculiar type of gait, and combined with that, a specific type of trembling. James Parkinson wasn't quite right in interpreting the movement abnormality he saw. He thought it was a sign of lessened muscular power. And therefore he chose the name Shaking Palsy to make a syndrome out of these 2 phenomena, the tremor and the movement disorder with the slowness and the postural abnormality and the gait problem. And it was only much later that the German philosopher Wilhelm von Humboldt, who contracted Parkinson's disease without knowing it, he made the observation that it wasn't palsy. He clearly wrote to a friend that this movement disorder was different from being weak. It was a strange awkwardness in movement, he called it. But anyway, Parkinson got it right, and he made this diagnostic concept, and he probably saw on the street images like this. This is a picture that Andrew Lees dug out in one of his recent papers, reviews, showing a scene from the times of James Parkinson in the prison yard of a London prison somewhere between 1808 and 1811. This is James Parkinson's times, and it's easy to see, looking at this gentleman depicted here, that one could be impressed, like James Parkinson was, with a particular pattern of movement abnormality. And the person, the famous neurologist Charcot at the Salpêtrière in Paris, who was, as you know, the person who first suggested to name the condition after James Parkinson and call it Parkinson's disease, in his famous Tuesday lectures, he made a statement like you see on the slide. He says he's seen such patients, as described by Parkinson, everywhere on the streets of Rome, of Amsterdam, in Spain. Obviously, there was no lockdown at the time, so one could travel. And it was always the same picture. And he's concluded by saying they can be identified from afar, and you don't need a medical history, let alone a medical exam. That was the view. Now, in some ways, this has persisted over more than 200 years as far as the clinical syndrome goes. We still, and the recent Movement Disorder Society criteria are an example, we still anchor our diagnosis of Parkinson's disease on the presence of cardinal motor features, bradykinesia plus rest tremor rigidity. we have progressed, of course, considerably in understanding the underlying pathology of this clinical syndrome and have a neuropathological definition, which until recently was unchallenged in requiring the presence of Lewy body type pathology, synuclein positive neuronal inclusions and cell loss in the substantia nigra and other brain areas. But that has been challenged recently, and we have other additional issues with this classical concept of defining PD. First of all, when does the disease begin? We assume, with good reason, that it will begin much earlier than at a stage that James Parkinson or Charcot were able to observe to make their observations in. We do know that not only nigral cell loss, but also other nervous system areas have neuronal pathology before there are any motor features recognizable or noticeable by patients themselves or observers. And we have evidence that the pathology in Parkinson's disease involves extranigral sites before affecting the substantia nigra. And the motor syndrome is only one side of the disease. Non-motor symptoms are an important part, and they may even antedate the onset of motor features. And finally, the pathological concept has also been challenged by genetic findings, for example, in LRRK2 Parkinsonism, where nigral cell loss may not be associated with synuclein pathology, Lewy body pathology, but for example, as seen on this image from the paper by Baubenjat and colleagues, by tau positive neurodegeneration in the nigra, leading to the notion that Parkinson's disease, as we have defined it for 2 centuries, may not be a single disease entity. And there's a more fundamental, practical, everyday problem that I want to remind you all of, and that is that even without those concerns about rarer cases of LRRK2 Parkinson's disease with tau pathology, there is a common everyday clinical problem in making a correct diagnosis of Parkinson's disease. The slide I'm showing you is about 20 years old. The paper is about 20 years old, but I think it is a very good example of the problem. It was conducted, the study was conducted by Annette Schraag and colleagues in London, and they looked at patients, more than 130, that had received a diagnosis of Parkinson's disease, but were doctors that were not specialized in movement disorders. They were general practitioners or general neurologists, and these diagnoses were reviewed by a panel of movement disorder experts as the gold standard arbiter for correctness of this diagnosis. And in that particular study, 15% of those that had been diagnosed by generalists as Parkinson's disease had alternate conditions listed here, including the atypical syndromes like PSP and MSA, but also tremor disorders. And conversely, when the authors analyzed the gold standard diagnosis, those 124 patients that were by expert clinician criteria bona fide Parkinson's disease, again, 19% had not been diagnosed as such, had received misclassification diagnosis, remarkably often non-Parkinsonian tremor diagnosis. So we have a problem, and the problem is further exemplified by this study, a meta-analysis of clinical pathological series, where we can really be sure this is not gold standard expert. Even gold standard experts are maybe subject to error. This is based on pathology. And from this meta-analysis, which covered overall around 1,000 patients in the literature, you can see that the diagnostic accuracy of what clinicians diagnosed versus what pathologists could diagnose as Parkinson's disease is suboptimal. Non-experts did worst, so to speak. There was 74% accuracy if the diagnosis had been made by non-experts, but even the movement disorder experts at first visit only got it right in about 80%. And that improves as patients are being followed longer. This is called after follow-up. It's improved by using standard criteria, but still overall we're talking about 81% diagnostic accuracy. And that's why we need additional markers to enhance this type of accuracy. And I will talk in the next section a little bit about imaging. What can imaging do to enhance diagnosis of Parkinson's disease? There are multiple methods, and I will not go through all of them, that have been used, imaging methods to study Parkinson's disease. It all started historically with a fundamental breakthrough paper in the 1980s, showing that in Parkinson's disease, you can actually, with radio tracer PET imaging, show the asymmetric denervation of the putamen or the striatum. And I still vividly remember the goose pickles, that cover picture in the issue of Nature, that caused everybody of us who saw that as young movement disorder neurologists. But I want today focus on MRI, because MRI is an evolving technique that has considerable amounts of information to offer when it comes to studying Parkinson's and to making a diagnosis. It is not only the diagnostic process that can be aided by MRI studies of the brain. In Parkinson's, we can get some insights into pathophysiological mechanisms and also into progression. I want to focus on diagnosis and want to review areas where MRI results can contribute, and that relates, still with a bit of a question mark, and further studies are needed, to its ability to detect prodromal stages. I will unfortunately not be able to show any sign in the MR that would be 100% specific of Parkinson's, but certainly supportive. And I will review some studies, including the ones we've been involved in, where MRI is clearly of value to aid the differential diagnosis versus atypical degenerative Parkinsonism, where most of the problems, at least in specialists' hands, occur at the bedside in making the correct diagnosis. The methods that MR uses to detect pathology have become very sophisticated. And when it comes to the substantia nigra as one core site of interest to look for Parkinson's disease specific changes with MRI, iron content has been a traditional interest, and neuromelanin has become possible to image indirectly and is important. There's also been diffusion tensor work to study the structural integrity of the substantia nigra in Parkinson's disease, but most importantly, and I will show that, diffusion techniques have been used to study the basal ganglia overall to detect tissue pathology in MSA and PSP that will help in clinically identical cases of Parkinson's, variant of MSA and Parkinson's disease, tissue changes that are not found in Parkinson's but are found in MSA. So diffusion techniques are important. And I will also show that velometry and of whole brain, has become a very powerful tool when it comes to making differential diagnostic decisions in Parkinsonism. Now, looking at the substantia nigra with MRI, that has become possible through neuromelanin imaging. Neuromelanin, of course, is at the very beginning of our understanding of the pathology of Parkinson's, with Tretyakov's observation in the early 20th century of depigmentation of the melanized nigra as a sign of cell loss of melanized neurons. And melanin is a complex structure, a complex cellular inclusion consisting not only of the melanin itself, that is a product of dopamine metabolism, but also inclusion of lipids and iron in the neuromelanin organelle. And it's the iron that gives melanin containing neurons paramagnetic properties and thus enables MR visualization of the neuromelanin rich substantia nigra compacta, and by the way, also the locus ceruleus and subceruleus complex, and with high resolution spin echo T1 images, the sensitivity is there to detect neuromelanin by an area of increased signal intensity against the background, as shown on the slide, where you can see a healthy control section through the midbrain with ROIs placed in the substantia nigra, displaying this increased signal intensity against the midbrain background, and areas can be calculated and contrast ratios can be formed between these areas and a background area. And only with the naked eye, one can see in a Parkinson example that there is decreased signal, particularly in the lateral parts. And interestingly, some cases of presumed prodromal RBD have also been published. Prodromal Parkinson's disease, i.e. RBD, have been published showing some degree of loss there. Overall, without going into individual studies, meta-analytic examinations of 10 studies published to date of neuromelanin imaging with MRI in Parkinson's disease against controls have shown these types of sensitivity and specificity above 80%, but this is against healthy controls, of course, and an issue remains that I will come back to later about how to distinguish Parkinson's disease from mimics rather than from controls. Now, another anatomical aspect of the substantia nigra that has had recent reflections in MRI imaging is related to the cellular architecture of the substantia nigra. I'm showing you a slide from a famous landmark paper published by Damier and colleagues and Gabriel Ivagit more than 20 years ago in Brain. And this is a beautiful study of the differential patterns of cell loss in the substantia nigra of Parkinson's disease. They used calbindin immunoreactivity to distinguish between the calbindin-rich matrix zones of the substantia nigra pars compacta and the calbindin-poor but cellularly densely packed areas they called nigrosomes, and they had the largest such area, which they had 5 that they detected, nigrosome 1 in the ventrolateral aspect of the substantia nigra. They identified that area as the one with the most severe cell depletion in their Parkinsonian cases. And a very nice study of selective vulnerability inside the substantia nigra. And that has come back to attention based on an imaging study that was, if I remember correctly, first presented at the MDS Congress in Sydney by the Nottingham group. They had used 7 Tesla MRI to study the substantia nigra. And they had, that was a beautiful feature of the study, also used post-mortem sections of the brain and perform immunohistochemistry to try and locate this signal they saw in normal people, a signal they called a nigrosome 1 related signal initially. Later, because of its morphology, they referred to it as the swallowtail cell, which is an ovoid area of hyperintensity in the dorsal lateral part of the substantia nigra against the hyperintense background of the nigra, nicely seen here. And they used 7 Tesla MRI. And I think Klaus Seppi in our group was probably the first shortly after to show that you can also detect this type of ovoid signal hyperintensity using susceptibility weighted ion sensitive imaging at 3 Tesla. And while this is being called nigrosome 1 imaging, of course, there is some question as to that is really histologically true. We prefer to call it dorsal nigral hyperintensity. And in a meta-analysis that Philipp Malknecht conducted in our group, from a total of 10 studies looking at this in Parkinson's disease and controls, the sensitivity and the specificity were quite high, and they were not significantly different between the pooled studies and those that looked at 3 Tesla MRI 7 only. So even with 3 Tesla MRI, you get close to 95% specificity against controls. A problem with this, of course, and I'll come back to this in a moment, is that when we studied it in all types of degenerative Parkinsonism and pooled our patients with Parkinson's and MSA and PSP, we found loss, at least unilateral loss of this signal, which is the pathological feature in Parkinson's disease, this unilateral loss of this feature also in the atypical Parkinsonism. So there's no way to distinguish them from Parkinson's. What is interesting though, is that loss of this signal, as we see it in Parkinson's disease, in more than 90% of Parkinson's disease patients across studies, loss of the DNH hyperintensity at 3 Tesla with SWI. You can also observe it in a fair proportion of patients with idiopathic REM sleep behavior disorder, i.e. presumed prodromal Parkinson's disease. This is from a study we did some years ago together with our colleagues in Barcelona, looking at a group of Parkinson patients, controls, and 13 subjects with idiopathic REM sleep behavior disorder. And while more than 90% of PD patients had at least unilateral loss of DNH signal, 77% of RBD patients had the same, and only very, very few controls, 1 of 35. So this is an interesting marker, of course, to follow when it comes to pinning down prodromal phases of the disease as a potential early sign of nigral pathology. Now, what I want to say, and what I did mention already, is none of these nigral pathology features MRI can detect in Parkinson's disease. And this also includes something I have not touched upon, tensor-based nigral imaging, free water imaging, which is also pathological in Parkinson's, cannot distinguish Parkinson's disease from other degenerative Parkinsonisms like MSA or PSP that equally affect the substantia nigra, sometimes more severely so than it is affected in Parkinson's disease. So in trying to get an MR handle on this distinction, diffusion-weighted imaging has been used, and I think it was probably fair to say that Klaus Sepp in our group was the first in the early 2000s, late 1990s, that pointed out that there is increased putamen diffusivity in MSA, which is not found in Parkinson's. And meanwhile, we have performed a little meta-analysis of these early WI studies with putamen diffusivity as the MR outcome, in assessing its value to differentiate Parkinson's disease patients, particularly from those that are the most difficult to differentiate clinically, the Parkinson variant of multiple system atrophy. And specificity was quite good, as you see, using this signal and marker alone. More recently, we and many other groups have become interested in automated subcortical volume segmentation based on T1 weighted MR images, performing MR volumetry, but using the free server software that was developed in Harvard, is freely available, to arrive at an automated observer independent MRI measurement of brain volumes that the computer can subdivide into neuroanatomically defined structures based on intensity, properties, atlas location, and relation to each other, both for cortical gray matter areas and white matter areas. And Christoph Scherfler in our group set out several years ago to develop a machine-based algorithm based on automated subcortical volume segmentation to see, can that distinguish Parkinson's disease from mimics like MSA or PSP. And this decision tree that you see on the slide, which is from this paper, shows that the midbrain is an important node, the cerebellar gray matter volume and the putamen volume, and using this stepwise algorithm where midbrain atrophy will identify PSP, cerebellar gray matter atrophy will identify MSA, and again, putamenal atrophy will identify MSA versus PD. The overall accuracy of this approach in that particular study, which of course was clinically diagnosed cases, and there were not early cases, but cases that had at least around 3 years duration on average. Under those circumstances, the accuracy was, as you see. We've recently been able, and this was mainly Florian Christmer in our group, to find a way to build in the middle cerebellar peduncle into this algorithm, which has not been part of free service so far. So Florian and Christoph succeeded to do that. And of course, as you all know, the middle cerebellar peduncle is atrophic and MSA. And when this was built into the decision tree, where infratentorial atrophy would now not only include gray matter loss and cerebellar atrophy, but also middle cerebellar peduncle atrophy, the classification of Parkinson's disease versus multiple system atrophy was near perfect only because there was one case that was clinically diagnosed as multiple system atrophy that passed through the decision tree, and the computer classified that case as Parkinson's disease. So there was one wrongly classified MSA case by this method. But this, I think, will be a future approach to our diagnostic clinical algorithm, that we will make use of automated algorithms, machine-based learning algorithms of MR features to recognize and distinguish. And by the way, just in passing, to give credit to the group in France, in Bordeaux and in Toulouse, Patrice Perron and co-workers, they have used a multimodal approach looking at different types of MR algorithms, not only gray matter density, but also R2 star or mean diffusivity, fractional anisotropy as tensor models depicted here as the different color codes. And interestingly, as we saw in our approach based on volume, it's the cerebellum and putamen that has the changes in MR parameters, different parameters compared in MSA compared to PD. And they, in that paper, found that combining two MR markers in a logistic regression model gave them above 95% discrimination. So that will certainly be very helpful in making clinically correct diagnosis, and hopefully early on, and this of course has to be acknowledged that many of these studies have not been in de novo cases, but those that had established clinical diagnosis. Let me move to the bench and the molecular biomarkers. There are many of those that have been studied in Parkinson's disease, and there is, as you all know, one, and that is genetics, that is part of clinical practice when we have to, when we define genetic subtypes of Parkinson's disease. And what I want to focus on in the final minutes of my talk is Sunuclean, and Sunuclean measuring in biofluids and tissues. And as you can see, we have studies looking at it in blood, in CSF, recently in tears, believe it or not, and a variety of tissues. Now, the CSF studies are probably the most numerous, and a meta-analysis in the Movement Disorder Journal some years ago found, well, a mixed message of encouraging and disappointing results, in that, for example, total alpha-synuclein levels that are decreased in Parkinson's disease, they're not very specific, and there's a huge degree of overlap between controls in Parkinson's disease. The oligomeric alpha-synuclein may be a little bit better. Fewer studies available, levels have been increased, but at the individual patient level, that's a difficult measure to be helpful as a diagnostic aid in the individual case. And that, I think, may be different with newer assays that look at the seeding activity based on our current concept that synuclein or tau, the proteins in neurodegenerative types of Parkinsonism, have prion-like properties, where they're able not only to self-aggregate, but to template native synuclein soluble monomeric forms into oligomers and fibrils. And these seeding assays, particularly PMCA and RT-QuIC, they have become standard diagnostic tests and have been incorporated into the diagnostic algorithms in prion diseases. And I want to briefly touch upon the studies we have now using these methods like RT-QuIC to measure the transition when a probe of CSF or tissue is brought in contact with recombinant human monomeric synuclein, going through cycles of elongation and aggregation, finally reaches a state of the amyloid protein situation with a certain lag time and then a certain rise until saturation has occurred. And this can be then measured, this seeding activity or event, using a thioflavin T fluorescence. And when this was done and is being done in patients with Parkinson's disease using CSF as the probe, the different studies have found remarkable degrees of sensitivity and specificity. They were not always 100%, but sometimes they were even 100% versus controls, using mostly Artiquick. Shavanas and colleagues in the Soto lab have used PMCA. But remarkably, as would be expected, these assays distinguish Parkinson's disease also from non-alpha-synuclein Parkinsonism like PSP and CBS. And in one study from Italy, this distinction between Parkinson's, PSP, CBS, the specificity was 100%. Intriguingly, the Soto group this year have found in using CSF from Parkinson's and MSA that they could distinguish the two conditions with high sensitivity. What they did was they used PMCA to detect aggregated alpha-synuclein, and they did indeed find in these samples from PD and MSA not only a different fluorescence signal magnitude in PD and MSA, but they found other differences concerning the aggregation kinetics, enabling them to distinguish based on the type of PMCA result, PD from MSA in the CSF. Now, as you know, synuclein has also been assayed in tissues, and the earliest studies, I think, were with colonic biopsies, and there have since been studies also on the salivary glands. Skin biopsies are probably the least invasive and an interesting approach. I will not go into those, but I would like to share a recent finding that we were able to make together with colleagues in Verona, Gianluigi Sanusso and his group, and the team in Barcelona, who we work with together for years now in the field of RBD, where we looked at the olfactory mucosa. Why the olfactory mucosa? Well, obviously, it's an interesting port of entry, quote unquote, in Parkinson's disease pathology, where the Bragg stages postulate that the olfactory system is one of the earliest sites of initiation of pathology. And then there have been results in the Jakob Creutzfeldt and the prion field that using swabs, nasal swabs from the olfactory mucosa, can detect, have a very good performance, even better performance than CSF in Jakob Creutzfeldt disease diagnostics. So we were interested in this, and the procedure is very non-invasive. We had it done through an ENT surgeon. It is a few minutes per nostril, or 2 or 3 minutes per nostril, and it gives a very brief unpleasant itching sensation. It's a soft swab that is inserted above the middle turbinate, but it's over in like no time, and the probe is then placed into a tube and processed for RT quick. We were able to study 63 subjects with idiopathic REM sleep behavior disorder as a potential prodromal Parkinson condition, Parkinson's disease and controls. And what we found in all the olfactory mucosa was interesting and disappointing at the same time. It was very interesting that we were able to detect this seeding activity in the olfactory mucosa, but it was only in less than 50% of the Parkinson patients, and we had some healthy controls as well. This is intriguing to interpret. What does it mean? Is it a methods problem here, or are we detecting at-risk people? And the same number of subjects as in the PD group had positivity in the RBD group in their olfactory mucosa. Now, this would not be, what you're looking for a diagnostic test in early disease, although the specificity of the two disease groups versus controls was high. And interestingly, in this little study, we also found a correlation with smell function. But it's something I think worth exploring, given the non-invasive nature and the repeatability, to better understand the temporal pharmacodynamics of synuclein seeding as we move from presumed prodromal conditions into the disease. I should mention that there is another Italian group that has published on this very approach, and they have present intriguing findings in MSA, in that they found in their OM, olfactory mucosa samples, some different biochemical features like the distance between over-twists in their fibrils that they obtained from PD versus MSA. So I believe this is an interesting approach to follow. Of course, what we would all like to see is bring the two things together, the imaging and the biomarker, the synuclein biofluid or tissue biomarker. The Michael J. Fox Foundation just very recently, I think about a week or two ago, has awarded their alpha-synuclein imaging competition sponsorship or prize to 3 teams. So we now have at least, I'm sure it's more around the globe, at least 3 teams that are working hard to try and find the alpha-synuclein imaging tool that we desperately need, and then maybe further advance our diagnostic accuracy and precision. So where are we after all these years and more than 2 centuries? I think we have, and we probably will never move away, I hope at least, from the clinical examination as being the anchor of our diagnostic process, but we will no longer be able to not use biomarkers. I think biomarkers, and that's in the clinic already true for imaging and genetics, and there will be other biofluids and tissues coming so that we will diagnose PD with more precision. We will be able to identify subtypes. We will hopefully get a handle on preclinical or prodromal stages of the disease, which is crucial to therapeutic concepts, into disease modification, and we will be becoming better in distinguishing Parkinson's disease from the mimics. With this, I would like to close and thank the key collaborators for those pieces of work that I alluded to, that we were involved in, alluded to in my talk, including the teams of the movement disorder group in Innsbruck and the sleep lab in Innsbruck, the radiology department in our university, and our collaborators in Barcelona, particularly Alex Iranzo and Eduardo Tolosa, and the group in Verona with whom we've teamed up, Gianluigi Sanusso and his colleagues recently. And I would like to thank the Movement Disorder Society again for this distinct honor with a photo that was taken when we were able to be live, face-to-face, last at the Congress in Nice. And as you can see, our hero, our founding father, is still up and strong in the front of the picture, Stan Fahn. Thank you very much, Stan.
Thank you, Werner, for this fascinating presentation and also for creating such a lively and warm atmosphere, even in a remote lecture. In normal times, I would give you a nice plaque and a big hug, all documented by our photographer. Both is not possible today, but the plaque will be sent to your home. And for the hug and the photo, we will catch up in Innsbruck, hopefully next